Morning, my name is Mike Samu. I'm a registered nurse at Eisenhower Medical Center's emergency department. I've been there for about 24 years. I'm also an SCRN, which stands for Stroke Certified Registered Nurse, and MICN, which is Mobile Intensive Care Nurse. I've been with the stroke program for quite some time now, I think probably around 7 or 8 years. And it's become kind of a bit of a passion for me and for Eisenhower itself to help stroke patients and also to help prevent stroke patients through education. We can go to the next slide. So this is our our hospital-wide stroke team. Dr. Solari is our director of the stroke program. He's a neurovascular stroke doctor. Dr. Joni Clark, also a vascular neurologist. Andy Al is our stroke nurse practitioner. Nydia Torres is our stroke nurse practitioner. And then our new stroke coordinator, and she forgot to change her name on there, is actually Kathy Cash, and she's the new stroke coordinator. She just took over a couple of weeks ago. We can go to the next slide. So Eisenhower is an advanced primary stroke center. We have to provide evidence-based quality health care. We're audited basically yearly. Sometimes it's every 2 years, sometimes it's every year. It just depends on which governing body is looking at us that year. We were the first stroke center in 2009 in Riverside and San Bernardino County to achieve that certification. Next slide. Stroke facts. Stroke is the leading cause of disability in long-term care in the United States. It costs America approximately $33 billion each year to care for stroke patients. Next slide. Strokes occur more frequently in men than they do in women, but more women die from stroke than men. Strokes kill twice as many women a year as breast cancer. A lot of people will know that breast cancer awareness, and I take nothing away from breast cancer awareness. I think breast cancer is an awful disease. And everybody can tell me that what month is Breast Cancer Awareness Month, and that would be October. But I don't know if too many people would be able to tell me what Stroke Awareness Month is. It's just not publicized enough, in my opinion, and that's May, by the way. I just think that with as dire epidemic as stroke really is, we should be spending more, paying more attention to it nationally as we are. Next slide. Some stroke facts. 795,000 Americans will have a stroke every year. That's every 40 seconds somebody has a stroke, and every 4 minutes somebody dies from a stroke. Stroke is the 5th most leading cause of death in the United States. $6.2 million will suffer a stroke worldwide. And stroke is the 2nd most common death in the world. It shows that the United States is actually fairly advanced in the worldwide in treating stroke. Most areas don't have the technology that we do. So we're very fortunate to be here where we actually have made it such a easy, or not easy, but common to treat the actual stroke symptoms. Next. Stroke is a transcontinental, silent transcontinental killer. It's not usually typically painful, and people kind of ignore the symptoms of it, which we'll get into a little bit later. So what is a stroke? Stroke is a disease that affects the arteries leading to and within the brain. A stroke occurs when a blood vessel that carries the oxygen and nutrients to the brain is either blocked by a clot or bursts. The brain doesn't have the capabilities of holding oxygen and sugar in it, like as a storage, as other parts of the body can store things. So any disruption of blood flow to the brain will in sense shut it down. That's why, you know, if you've ever watched wrestling or anything or mixed martial arts and they choke people out and they pass out, it only takes a few seconds of holding somebody in a chokehold, including the carotid artery, to actually knock the person out. And that's because the brain doesn't hold enough storage of oxygen to keep it running, and it will close down to protect itself. The next slide. There are essentially two types of stroke, two major types of stroke. One of them is a clot obstructing the flow of blood to the brain, blocking the blood frame. We call that a dry stroke, and that's an ischemic stroke. That's 87% of all strokes are ischemic strokes. Then you can have a blood vessel rupturing inside the head, inside the brain, and disrupting the flow. And that is a hemorrhagic shock, and that's 13%. There's a few subcategories of these strokes, but those are the two main categories of them. Next slide. An ischemic stroke, as you can see from the diagram, which would be on everybody's right, is you can see they have it kind of pointed. A little blood clot blocks the flow of blood to the brain, and the brain tissue starts to die and shut down and die. And in a hemorrhagic stroke, a blood vessel breaks and blood scatters into the brain tissue, and the blood itself is fairly toxic to the brain tissue and will cause severe damage. Wake-up stroke is a subcharacteristic of a stroke, a subclassification. It's basically when you wake up in the morning and the symptoms are there. They weren't there when you went to bed. So stroke symptoms are present upon waking. The last seen normal is when the patient went to bed. And the reason we say it that way, last seen normal, is because that's a very important time frame for us in the emergency department. Between 8 to 28%, that's a pretty big gap, but that's what the studies show, are wake-up strokes. The reasons for this are that the blood pressure is typically higher in the morning. Most people take their blood pressure medications in the morning. And so when they wake up, it's been a full 24 hours or so since the blood, since they took their blood pressure medication. The other is dehydration. Most people are pretty dehydrated in the morning. They don't typically wake up in the middle of the night and drink water. And so they're kind of dehydrated. And so the blood has a thicker viscosity and tends to clump up easier. Other factors are your platelet aggregation in the morning is at its highest first thing in the morning, partially due to the dehydration. Next slide. TIAs. People will call TIAs mini strokes. I hate that term. Absolutely think it needs to be stricken from the human language. It's really not a mini stroke. It has the exact same symptoms as a stroke. It's not a minor or mini anything. It is a warning sign stroke, one that we should take very seriously. TIAs are symptoms of a stroke, the same symptoms of a stroke, but they go away on their own. And that's really what it is. It goes away on its own, less than 24 hours. But here's the rub, here's the problem with that. If you're waiting for them to go away and they don't go away, we have very limited time in the emergency department where we can actually act to prevent the stroke from progressing. Okay, so we have to take it very seriously. Strokes, TIAs and strokes have the exact same symptoms. I have had patients that are 100% paralyzed on one side, unable to speak, can't move at all. The family brings them in, we stick them in the scanner, and they come out of the scanner able to move, able to speak, and the symptoms are completely gone. That's a TIA. Now, if that didn't go away, we would have had to treat it. So please don't wait to see if they go away on their own. Call 911, get the patient to the hospital as soon as possible, because if it doesn't go away on its own, you're looking at a long-term disability. Okay. So what are the signs and symptoms of a stroke? Stroke symptoms come on suddenly. They rarely come on gradually. The sudden symptoms are sudden numbness or weakness in the face, arms, or legs, especially on one side of the body. It's almost always a hemi, one side or the other. It's typically not mixed in any way. There are a few very odd strokes that do that, but those are rare, so it's not really worth getting into. Sudden confusion, trouble speaking. And when I say confusion, it's not as much like I don't know where I am, or I don't know things. It's unable to speak, unable to get your point across, seem very disoriented. Those typically are the signs that we're talking about. Particularly the inability to speak, inability to form words, people try to say something and either gibberish comes out or words come out that make no sense at all. Those are the signs of a stroke. Sudden trouble seeing in one or both eyes, especially the visual field cut, not really floaters, or if anybody's had floaters in their eyes, that's not typically a stroke problem. It can be, but it's not typical. But like a visual field cut where you don't see, like an entire section of your vision is missing, that can be stroke. And sudden dizziness or headache. One type of stroke is called a subarachnoid hemorrhage, and that has what they call like a thunderclap headache. It's typically called, but it's not always, the worst headache of their life. It comes on extremely suddenly. That headache also tends to come with some neck stiffness and pain in their neck. And then just plain sudden dizziness, the B.E.F.A.S.T, the dizziness is some of it. People get vertigo when they have symptoms where the room is spinning and they have trouble walking. Vertigo, as somebody who suffers from vertigo occasionally, comes on gradually. Like you can feel it coming on. I know when I'm going to have an issue with vertigo as it's coming on, because it takes maybe a half hour, 40 minutes to really start to spin. Posterior strokes, which is a type of stroke, is usually sudden onset where you're perfectly fine, and then like every other symptom of stroke, you're perfectly fine, and then with the snap of a finger, you have the weakness on one side or the inability to speak or something like that. And that same thing comes with dizziness, and a posterior stroke will cause sudden onset dizziness where you're perfectly fine, then all of a sudden the room is spinning and you're walking like a drunken sailor on the deck of a pitching ship. Okay, next slide. So this is a very famous representation of what stroke, and it's easy to understand. We used to say act fast, and we use the FAST as a acronym to show you what we're looking for. So you're looking in the picture and you're seeing this woman with drooping on the left side. She has like a flattened labial fold. Her face is pointing downward and she can't raise it. You can ask people to smile and one side of their face won't go up as much as the other, if at all. And then arm drift, inability to hold things. Sometimes they'll be going to take a drink of something and their hand won't be able to hold it up. It'll just drop. Even if it's weaker, they're having trouble coordinating that arm to do what it needs to do. Or it could be the leg. Their leg is weak. All of a sudden, their leg becomes much weaker, and they can't hold themselves up or move it properly. Speech. It can be slurring of words, such as their words are sound wet, or inability to actually articulate the words. They're saying the proper words. They're saying what they need to say, but it's very slurred. I hate to keep using the term, but it's like they're very drunk and they can't get the words out. The other type of speech problem, another type of aphasia, is where the words just don't come out. They're trying to say something and just nonsensical words or sounds just come out of their mouth. That's typically its stroke symptoms. And then we use time, because time is of the essence. We need to get that person to the emergency department as soon as possible. And of course, I prefer you call 911, and I will get into that a little bit more later, but we really want the person, because treatment can start and our system can start when the paramedics arrive at that home and start assessing the patient, as opposed to driving them there, dragging them across a parking lot, walking into the emergency department to, in a sense, surprise us with this patient. And then we have to get our system running. We're always ready, but EMS gives us a 10-15, they can contact us early, give us a 10-15 minute head start. Next slide. B.E.F.A.S.T. I actually got to meet the woman who came up with this. She was a stroke coordinator from the Midwest. She noticed that with the ACT fast, we tended to miss the posterior strokes, which is the balance issue and the visual problems. So she added the BE to the FAST. And so that's the balance, sudden loss of balance, dizziness also goes with that, lack of coordination, and then the visual disturbances, blurred vision, double vision, field cut vision, and then back to the face, arms, speech. They also have in there severe headache and time. If you see any of those symptoms, particularly when they're sudden onset, again, that's immediate report to, call 911 and get people there. Next slide. So because of that, because I'm not out there wandering the streets looking for stroke patients, neither is EMS, you're the first link in the chain. Click again. You're the big piece of the puzzle. Stroke is a medical emergency and time is of the essence. Okay. So whenever you see somebody with stroke symptoms, or you're having stroke symptoms, if you're able to, you want to immediately dial 911 if you have a cell phone. There's actually a little button on your phone or a little place on your phone you touch and it dials 911 immediately for you. Then you want to get to the emergency department to be evaluated. Don't wait to see if the symptoms go away. Don't hope it's a TIA, even if you've had them in the past and you've been fine. You don't know that. Most people that have had TIAs is just a warning sign saying a real stroke, a big stroke is coming your way. So time is brain. When I say that, I mean 1.9 million neurons die each minute. And it's all about saving the penumbra. Time is of the essence. Now, as you can see from this photo, there's a little yellow blood clot. They're not really yellow, but anyway, there's a little yellow blood clot in depicting this picture exactly. And then you have an area of dead tissue. Now, once the tissue's dead, there's nothing you can do about that dead tissue. However, the area surrounding that is called the penumbra, and as you can see, it's significantly larger. And if you are able to stop the death of the tissue, the body has this wonderful ability to rewire around that dead tissue if it's not too large. This is why you see stroke patients over time, over months to even years, regain the ability to walk, regain the ability to feed themselves, regain the ability to speak. Because if they were able to hold the tissue to a small part of the brain, the death of that tissue, the body will basically rewire around it and give you most of, if not all of your functioning back. Next slide. And this is progression of a stroke over time. The red part of the stroke is the dead tissue. Nothing you can do about that. Once you're dead, you're dead. The rest of it is not. If you keep waiting and seeing if it's going to go away on its own, or I'm going to drive my loved one into the emergency department and things aren't explained right, the longer you wait, the more dead tissue until you have the entire area of ischemic tissue is left dead, and there's really not much that's going to be done about that. And the recovery of that person is unfortunately not going to happen. Next slide. So how do we stop the progression of the stroke? What does the emergency department do that, and the hospital in general do, that prevents furthering of the stroke? So we have a medication that is out there. It's called TPA. Alteplase is its trade name. And we use TPA given intravenously under most conditions to basically break up that clot and restore the blood flow to the brain. And once we are able to administer this medication and restore the blood flow to the brain, then the stroke essentially stops, and then it's just, you're in the recovery phase. The key to this is we have to have the patient in the emergency department and start TPA within, best before, but always earlier the better. But the kind of one of our walls is 3 hours. And then some patients, depending on their age, their health, the size of the stroke, and other extenuating circumstances, we might be able to push it out to 4.5 hours, but that typically doesn't happen. 3 hours is kind of the FDA and medically accepted kind of window. So the sooner you notice somebody has the stroke, having symptoms, the sooner you get them to the ER, and the sooner you get them treated, the better the outcome. Next. Or if you wake up with the symptoms, and so you don't know when the symptoms started, it could have been at 11 o'clock at night when they went to bed, 8 o'clock at night when they went to bed, or 5 minutes before the stroke, before they woke up. You know, still time is of the essence. That's not a time where you go, oh, well, it's already happened. Nothing we can do about that now. Let's just see if he gets better. No, you still want to call 911, get them to the hospital, because there still may be something we can do, and that would be the next slide. We can do what's called a thrombectomy. We're extremely fortunate at Eisenhower. We have, I think we have 3 interventional radiologists that can actually go up with the wire, just like when people have heart attacks and they go into the cath lab and we open up the blood vessel, they can actually go up into the brain, into the blood vessels of the brain with a device and pull the clot out of the brain, stopping the stroke and saving tissue. And they'll do that up to 24 hours. That's kind of the hard stop. But again, the sooner you get the patient in, obviously the better. So if you can get them in 4 hours, 5 hours, all the better. The more brain tissue is saved. Next slide. You can actually see from this is actual scans during a procedure where you can see that there's a narrowing of the blood vessel. There's an obvious blood clot, and they're just showing different angles of it. And then they open up the blood clot, and you have blood flow restored. It's amazing to see. I've been in the cath lab when they've opened up the blood vessel, and I had a woman, the first time I've ever seen this, a woman came in, she was having a stroke. She was completely paralyzed on her right-hand side. She couldn't speak. And I got her into the cath, I brought her up to the cath lab. We didn't really have a last time seen normal on her at all. Family came over and she was found. They took her to the cath lab. They did the percutaneous insertion. They went up into the brain, and I was actually standing there watching as he got to where the blood clot was. He withdrew that blood clot, and she used her right hand to reach up and scratch her nose. And when she left the hospital, she had almost no deficit, if any deficit at all. Slide. So the most important question you can ask if you suspect somebody that's having a stroke, or you see somebody that has stroke symptom, is, that's exactly right, time last seen normal. Not when you notice them, not when they think it might have happened, but when was the last time the person was seen completely normal, had no symptoms at all? Was it when they went to bed at night? If you wake up in the morning and you say, I'm going to the grocery store, and you tell your husband or your loved one, I'll be back in an hour, and they're sitting there saying, fine, reading the newspaper or watching the news, and you come home and they've spilled their coffee and they are left to the side, but you've been gone 2 hours, the time last seen normal is when you walked out that door at 2 hours ago. Because we don't know if they sat there for 5 hours or for the full 2 hours and the symptoms happened immediately when you left, or just before you got there. Why is it so important? Again, we're going back to the same thing I said earlier. 3 to 4.5 hours of the onset of stroke is when it's the safe and most effective for TPA to be started. Again, call 911. We've had patients that have brought their family members in. They think if they're saving times, oh, I'm only 5 minutes from the hospital. Well, it takes you 10 minutes to wheel the person, to get the person, because you're partially dragging them to your car. You think it took you 30 seconds because you're working so fast, but you're not. It takes 5 minutes to drive to the hospital. You have to find a parking space, which is always wonderful at the hospital. We love the parking there. Not so much. And then you have to try and get a wheelchair, get the person in the wheelchair, bring the patient in, tell the triage nurse, I think my husband, my wife, my sister, my brother is having a stroke. And then they're going to start asking questions like, when did you last see the patient normal? What symptoms are you talking about? Why do you think they're having a stroke? All that takes time. And then they bring them they activate our code 10, bring them to the code 10 deck, start working, then we get the team assembled, start getting things together, get the patient to the CAT scan, bring the patient back to the room, reevaluate the patient, have all the blood work started, start an IV, you're talking from the 5 minutes from the hospital. Now you're talking it's been 45, 55 minutes, which is a huge amount of time. 1.9 million neurons die in a minute. A lot of neurons have died in that time. While if you had called 911, okay, maybe it takes 7-8 minutes for the paramedics to get there, but they get in, they do a very quick evaluation, load the patient up, start an IV, call us, ambulance pulls into the inn, they wheel the patient directly to the deck. Everybody's waiting for them. CAT scan is cleared. We wheel them immediately over to CAT scan, do our scans, bring them back to room. And if everything has worked in the right favor, it's less than 2-3 hours, they have all the symptoms we're looking for, the CAT scan is negative for a bleeding stroke, we start the TPA. So you might think you're saving time by driving them the 5 minutes to the hospital. You're really not. So please call 911. Paramedics can start the treatment immediately. Like I said, they'll have an IV for us, maybe 2. I love that picture. Some of us remember when the ambulances actually looked like that. Next slide. They can contact us immediately. So we're all ready to go when the paramedics arrive with your family member, and we can start treatment immediately. Follow the ambulance. Now, not all the way to the ambulance bay because you won't be let in that way, but follow the ambulance to the hospital because we'll have some questions for you once you arrive at the hospital. The paramedics will give us a quick down and dirty of what's going on, when was the last time seen normal, things like that, some of the medications and allergies, but some of it is more they might not get from the family, so it's important for us to be able to question a family member as to what medications they take, when was the last time seen normal, because believe it or not, that answer tends to change even with the paramedics, and a brief medical history. Stroke equals brain attack. People like to say people are having a heart attack and they know it's an emergency. Oh my gosh, I think my husband's having a heart attack. Oh my gosh, I think my husband's having my wife's having a heart attack. Because it's painful, people run in with the pain. Because strokes are typically not painful, people don't treat it as an attack. A lot of us would like to see the name stroke be changed to brain attack. Stroke is a treatable disease if you get the patient to the hospital immediately. So become a stroke ambassador. This message that I'm giving you today, this information I'm sharing with you today is something that you can carry with you. You take with you. You have this knowledge base now. So if somebody's having these symptoms of a stroke, or you recognize symptoms that other people might not recognize as symptoms. A patient several years ago had a stroke, and he actually finally got 911 called on his phone. And even the 911 operator, when he was trying to speak and nothing but gibberish was coming out of his mouth, she's like, "Are you drunk?" We heard the 911 tape. "Are you drunk? What's the matter with you?" So they sent the police to the house, which is standard, and the police officer recognized that he thought it was a stroke and told the 911 operator, "Hey, I think this is a stroke. Get an ambulance on the way here." So now that you have this knowledge, you don't have to be that 911 operator that says, "Are you drunk?" if somebody's slurring their words. You'll recognize the symptoms. Next slide. For more information on stroke, you want to contact the American Stroke Association, or you go online to the strokeassociation.org. Next slide. Stroke prevention. The risk factors for stroke are the same as heart attacks. Um, there are some that you can control, and some you can't. The ones you can't control is your age. Facelifts and Botox do not change your age. Dyeing your hair doesn't change your age. You can't change your family history. Your family history is your family history. If your family has a high history of stroke, has a history of high blood pressure, has a history of heart disease, you have that same history. Even if you're in particularly good shape, you're better off than maybe some of your family members, but it's still a family history. You can't change your race and you can't change your gender. Again, Blacks, Hispanics, Native Americans tend to have a higher incidence of hypertension and diabetes, which are risk factors for stroke. And again, more men will have a stroke than women, but more women will die of a stroke. Typically, the reason for women dying of a stroke more than men is because women tend to, I don't know if it's because they eat better than men or for whatever reason, women have their strokes later in life. A man can have strokes typically have strokes earlier in life, 60s, 70s. Women typically like to wait till they're in their 80s to have a stroke. So as you get older, your risk of symptoms being worse and the ability to heal from them decrease. Things you can control is your blood pressure. You might not be able to prevent yourself from getting hypertension because of your family history, but you can control it. High cholesterol, again, you can control your cholesterol. If you're on a statin medication, you've got to make sure you take your statin medications. You have to eat a proper diet, proper human diet. Blood pressure, you have to take your blood pressure medication. Something, we get all the time. Oh, I ran out of that medication. Or no, I stopped taking it. It made me feel tired. One instance, a gentleman, they have blood pressure medications, as all medications, have side effects, especially for younger men. You can get erectile dysfunction from blood pressure medications. Well, this happened to a young man. He was in his 30s. He had very bad high blood pressure. And he was taking his blood pressure medication, and then he ended up with erectile dysfunction. Said, nope, not taking my blood pressure medication. Well, unfortunately, he died from a stroke. He ended up with a hemorrhagic stroke and died because he wouldn't take his medications. Keeping your blood sugar under control. High blood sugar is very, very hard on your vasculature, on your blood vessels. It's hard on in your eyes, in your kidneys, throughout the rest of your body, and yes, in your brain too. So it makes your blood vessels more friable and more weak. If you have atrial fibrillation and you're on a blood thinner, take your blood thinner. Make sure you don't stop it. If you are told to stop it by, let's say, your dentist, because this happens all the time, people will need to go see their dentist, and the dentist will say, oh, I'm going to have to pull that tooth. Make sure you stop taking your Coumadin a week before the procedure. Well, now you're going a week without blood thinners. This happens all the time, where we'll get a call from somebody in the family will tell us, oh, well, yeah, they were supposed to we'll see the dentist today, so they've been off their Coumadin for a week. If you have to go see your dentist and you have atrial fibrillation and you're on a blood thinner, before you go to your dentist, after you talk to your dentist, talk to your cardiologist and see whether or not they want to bridge you on a medication like subcutaneous heparin or something like that, where you can stop the morning of your dental procedure and start the day after your dental procedure. So instead of going a week without your blood thinner, you're going 24 hours. Much less, is there still a risk? Yes, much lower risk of having a stroke. Tobacco, smoking. Smoking is one of the, nicotine is one of the most powerful vasoactive substances on the planet. You can watch, I've seen video of nicotine being into a system and watching a artery go from, half a millimeter, 2 millimeters in diameter to 3/4 of a millimeter in diameter because of the vasoconstriction from nicotine. Increased activity. The more active you are, the better your blood flow is, the more healthy you are, the less chance of having a stroke. And being obese or overweight is also a major symptom of having or a major risk factor for having a stroke. And these are the controllable risk factors. Next slide. Sinus rhythm. This is the normal rhythm that your heart is supposed to be into. As you can see, it's very uniform. It's very effective. It's the way your heart is supposed to pump. Atrial fibrillation, which is the next slide. The top part of your heart isn't really functioning properly. It's not squeezing and sending all the blood through to the lower chambers of the heart. So when you have atrial fibrillation, you can have pooling of blood in the chambers of the atrium, which is the top part of the heart. And anytime you have blood sit still for any amount of time, it starts to coagulate, form a blood clot. If you take a knife and cut your hand and hold it in a pool in your hand, in a few seconds it'll skim over and you'll start to develop. It'll start to thicken up and clot. So that's why taking your blood thinner is so important if you have atrial fibrillation. Next slide. So lower your risk. What I said before. Monitor your blood pressure. Make sure it's working. Your blood pressure medications are working for you. If they're not, if you're running very high, see your doctor. See if you can add a medication to take so you can lower your blood pressure. Eat a lower fat diet. Take your medications as prescribed. If you're on blood pressure medication, take it. If you're on blood thinners, take it. If you're on cholesterol medications, take them. Limit your alcohol use. High alcohol uses in studies have shown higher incidence of stroke. Quit smoking and exercise regularly. Avoid being obese, which is which is often caused by lack of exercise. It also has sleep disorders, including sleep apnea. Sleep apnea is another. There's been studies that show that you have a significantly higher incidence of stroke if you have sleep apnea. More than 2 drinks a day can increase brain bleeding by 10-fold. I know they've said for a long time that a couple glasses of red wine a night is good for you. Well, some newer studies are saying that that's not exactly true, unfortunately, because most people really like that. Loved when they could say, I'm just having a drink because my doctor said so. But newer studies are coming out that are showing that it actually can increase the chance of having bleeding. And that's not counting the falling down and hitting your head part. And drug abuse, stimulants, cocaine, methamphetamines, things like that will raise your blood pressure, increase your heart rate, and can cause stroke. I know if anybody's been a school teacher, repeating things is how you get kids to learn. Well, it's no different from adults. So we repeat the same thing over and over again, as you can see. The modifiable risk factors that can be changed is the blood pressure monitoring, keeping your diabetes, and your blood thinners for AFib, and smoking. So some of the parameters that you're looking for like metabolic syndrome is if your blood pressure is over 130 over 85, if your waist circumference for men is greater than 40 inches around or 35 inches around for women. Triglycerides that are greater than 150, fasting blood sugar is greater than 110, or your low density lipids is greater than 100. He looks happy, but he's probably gonna have a stroke. So again, this is if you want to score yourself on your risk factors. If your blood pressure is over 140, you have an irregular heartbeat, you are a smoker, your cholesterol level is over 240, you're diabetic, you don't exercise, you're overweight, then you're in the high risk. And as you can see, the lower your blood pressure, not smoking, or trying to quit smoking, lowers your risk, and then the low risk. But it doesn't take all the risk away. A lot of it can also be genetic as well. Next slide. So the risk scorecard, high risk is greater than 3. You want to talk to your doctor and get in on and take these medications. This is a little busier. And again, remember the warning signs that we've been over a few times earlier. Next slide. Talk to your doctor, nurse, healthcare professional. Make them part of your health team. Go in regularly for checkups. The doctor might put you on a medication, and you might be on it for years thinking I'm doing just fine. And then all of a sudden you go in to see your doctor, or you stop by Walmart, check your blood pressure, and all of a sudden you're like, wow, my blood pressure is really high. I wonder why. Well, if you haven't been monitoring it, you don't know if it's been high for a very long time or not. When you're talking to your doctor, don't forget to tell them what supplements you're taking. There are certain supplements on the market that decrease the ability for your blood to clot. Vitamin E in particular will cause your blood clotting to slow down, which in some instances is good, some instances is bad. Whether you drink, whether you smoke, be honest with your healthcare provider. We don't pass judgment necessarily on you for your choices that you make in life. But it's important for us to know if you're telling us, I exercise every day and I walk 5 miles a day and I eat a healthy diet, but in reality you watch MTV, you watch TV all day and you sit and drink beer and eat potato chips, it's not helping you. Also whether you drink, people love to say, I only have 2 drinks, when the drinks are this size. That might be 1 drink to some people, but it's 12 to other people. So you want to watch your lifestyle choices and use your and use your health team to help you, telling them the truth. Again, you're the first link in the chain. Next slide. Big piece of the puzzle. Remembering the B.E.F.A.S.T model and notifying EMS to get the person having the symptoms to the hospital as soon as possible. is the biggest thing you can remember. Next slide. Again, call 911 because they can get things started sooner. Does anybody have any questions?
All right. If anyone has any questions, feel free to unmute yourself and go ahead and ask a question of Mike.